Hello, my name is Ivan Wong. So thank you very much for joining us today. This is our first Sports Medicine Journal Club of the 2021 academic year. So thanks so much for joining us virtually tonight, and we hope that you get to enjoy this. This is our hybrid journal club event, and want to take a moment to thank the members of our sports medicine team for joining me and our research team for making this virtual portion of the event possible. So the topic of tonight's journal club is ACL tears in the young active hyperlax patient. Our journal club will begin with a case presentation, and then we'll follow up by presentations of two relevant articles and have discussion for each. So please take a moment. You're going to be on YouTube here to make sure that you're logged in, that you can send your questions in because they'll be interactive. It'll appear on the bottom of the screen, and we'll do our best to kind of answer them during the event. We also welcome any feedback you may have so we can improve future broadcasts. So I'm happy to have both Dr. Kathy Cody and Nathan Urquhart here to contribute to tonight's discussion. And we're going to start off this event by introducing our guest moderator. So Dr. Brenden Sheehan is an orthopedic surgeon. He completed his medical degree at Memorial University in St. John's, Newfoundland. He then completed his orthopedic residency training at the University of Calgary, followed by a subspecialty training in the orthopedic sports medicine at UBC in Vancouver. He completed his diploma of sports medicine through the Canadian Academic Sports and Exercise Medicine in 2017. Brendan's accepted a position at the Department of Orthopedic Surgery in his hometown, St. John, New Brunswick, in September of 2015, and he's assistant professor with the Faculty of Medicine at both Dalhousie and Memorial Universities. His practice specializes in orthopedic sports medicine and knee and shoulder reconstructive surgery, with focus on minimal invasive arthroscopic techniques. Brenden is active in his research in knee and shoulder arthroscopy and holds a position of secretary at the Executive Committee for the Canadian Orthopedic Association, as well as the position on the executive for the Arthroscopy Association of Canada. Thanks, Brenden, for joining us.
Thank you, Ivan. It's a pleasure to be here. Looking forward to it.
So I have the pleasure of introducing Dr. Maude Joannette-Bourguignon. She was born in Montreal, Quebec. She completed her medical school as well as her residency in Sherbrooke, Quebec. Maude is extremely passionate in sports. She enjoys cycling and cross-country skiing, and we are so happy to have her here with us pursuing a fellowship in sport medicine in Halifax. Welcome, Maude.
Thank you. So hi, so we'll start with the case presentation and then the journal club about ACL rupture in a young and hypermobile soccer player. So we'll start with the case, then the two relevant articles. The case is a 15-year-old girl who plays competitive soccer. She has no past medical history, and 10 days prior to coming to the clinic, she sustained a non-contact pivoting left knee injury. She was initially unable to weight bear. She had significant effusion and pain. On physical examination, she had a neutral alignment, a Baton score of 7. She was only missing elbow hyperextension. She had effusion and limited extension. However, on the day of surgery, she had regained her full extension. She had a Lachman of 2 without endpoint, and on the first visit, we were unable to perform the pivot shift. However, after she returned after MRI, she had a pivot shift of 2, and she was stable in varus and valgus. So these are her x-rays that show no second fracture, no deep sulcus, and her physis are closed, so she is skeletally mature. And this is her MRI. So first we have a T2 coronal image that show a empty lateral wall sign. Then this sagittal view, you can see the bone bruise on the lateral femoral condyle, as well as hypersignal in the posterior meniscus, which we thought would be a complex tear. And then finally, that's an image in the notch that shows a high-grade ACL tear. So in summary, this is an ACL tear in a skeletally mature female. However, the problem is way more complex than just this, and there's different things to consider in order to plan a successful surgery for this patient. So first of all, she's a female, and we know that females have more ACL injuries and more re-injury and revision surgery. They have lower outcomes, and that might be because they don't return to sports as much as male. She's also 15 years old, so we know that this population has a higher rate of secondary ACL injury. She's also hypermobile, and some studies show that they have higher graft failure and lower outcome scores. And she also wants to return to soccer after her surgery, which puts her at higher risk of re-injury. And finally, she got a high-grade pivot shift, and some studies show that they might have residual instability after ACL reconstruction. So if we rephrase the problem, this is an ACL tear in a hypermobile, young but skeletally mature competitive soccer player. So should we consider different types of graft? So autograft hamstrings versus BTB or autograft quad tendon and a patellar bone block. As you can see, I did not put allograft in the list, as we know that there are more failures with allograft in a young population. And should we also consider adding lateral extraarticular tenodesis or ALL reconstruction for this patient? So what is anterolateral complex? So the anterolateral ligament was first described by Dr. Second in 1879, and it was described as a thickening of the anterolateral capsular fibrous band. And the complex is the ALL plus the IT band and the capsulo-osseous layer of the IT band. And the anterolateral complex prevents internal rotation of the tibia when the knee is flexed more than 30 degrees. However, it does not prevent intertranslation of the tibia. And how do we measure anterolateral complex injury? With the pivot shift. So ACL tear alone can cause a positive pivot shift. However, high-grade pivot shifts are usually caused by ACL and ALC tears. And you can see here, those are videos of a high-grade pivot shift in one of our patients from last week. And the other one, oops. Oh, okay, sorry. So what is lateral extraarticular tenodesis? So it was first described by Dr. Marcel Lemaire in 1967 as an isolated procedure for knee instability. So it is a strip of the iliotibial band that is passed under the lateral collateral ligament, and that is kept attached to Gerdy's tubercle distally, and it's fixed to the distal femur. So as you can see, it's the red rectangle that is passed under the blue rectangle, which is the lateral collateral ligament. And the technique was modified over time. Instead of using the posterior part of the IT band, surgeons now use the central part, and also the fixation changed over time. So there were a few different techniques that were described. Some are still used today. So what do we really know about LET? So in the literature, there are tons of cadaveric and biomechanical studies that show that it does reduce rotatory instability, so the pivot shift, and also the stress on the ACL graft, because it prevents the tibia from going into internal rotation. However, when it's compared to ACL reconstruction alone, it's not really clear if it improves the outcome scores, the failure rate, the return to sport. And also initially it was thought that it would lead to OA in the lateral compartment from over-constraint because of the graft. But initially the graft was also fixed in 30 degrees of external rotation of the tibia, and now it's fixed in neutral. And recent studies have not showed that it causes more OA than ACL reconstruction alone. And the studies available are mostly case series or studies with heterogeneous population. So we kind of need better studies to assess the benefits of LET or ALL in a high-risk population. But someone has been studying this for a few years. It's Dr. Gedgood from Western University, London, Ontario. So the first RCT that he published about this subject, we'll talk about this later. It's the first article of the Journal Club. And now the team is recruiting for the second study, which is Stability 2. So ACL reconstruction using BTB or quad tendon, more or less lateral extraarticular tenodesis. So for the Stability 2 study, the inclusion criteria was age 14 to 25, ACL deficient knee, being skeletally mature, and either participating in competitive pivoting sports, having a high-grade pivot shift or a Baton score more than 4. and the outcomes were failure of ACL reconstruction and patient reported outcome scores. And so there are 4 different groups. So bone tendon bone ACL reconstruction alone, or quad tendon and patellar bone block plus ACL reconstruction alone, or these 2 plus lateral extraarticular tenodesis. So highlighted in yellow, you can see that our patient had all of the inclusion criteria. So she was randomized to isolated ACL reconstruction using quad tendon autograft. So we did the surgery on August 11th. She had a left knee arthroscopy, and if you remember the MRI, she had a lateral meniscal tear, so we did a lateral partial meniscectomy. She had the ACL reconstruction using quad tendon, and the graft size was 9.5. So this is a short video about her surgery, and sorry, I was filming, and it's my first time recording for this purpose, so I apologize for the moving camera. Yep. Okay, please. It's not working. Okay, so this is a view in the notch. So you can see here there's an inflammatory reaction on the ACL stump, and there's nothing attached to the lateral wall where the probe is. So the ACL is healing on the PCL. This is the lateral compartment. So the you will see that there's a flap of the lateral meniscus close to the popliteus hiatus. And that the root is, there's a little fraying, but it was stable. So it looked way worse on the MRI, and that was the reason why we went to do the surgery acutely. So we used a biter and a smaller shaver to address the lateral meniscal tear. And the next thing you will see is a cartilage defect. Oh, sorry. So the meniscus after the meniscectomy was stable. So you can see here the cartilage defect that was probably from the initial injury. So we just shaved the cartilage. So here you see the lateral wall after the preparation for the tunnel. And this is the ACL stump. So Dr. Cody likes to leave as much stump as she can for those surgeries. So this is the graft harvest. So we use a oscillating saw to harvest 1 centimeter wide by 2 centimeter long bone block on the patella, and she uses a drill to pierce 2 holes in the bone block in order to pass the non-resorbable suture. This is a video from a different surgeon, so you see there's no bone block, but he used traction suture in order to help with the graft harvesting. So it's usually a 10 centimeter long soft tissue graft, more or less the bone block. And you can try to use the suture to make the blend between the vastus intermedius and the rectus femoris. Some surgeons close the interval, some surgeons don't, depending on if you open the capsule during harvest or not. And also surgeon preference. I think Dr. Cody closes the quad. And then we prepared the graft on the table. So Dr. Cody uses non-resorbable sutures for both ends and the Vicryl tool to go around the tendon. And we measured the graft that was 9.5. So this is the femoral tunnel preparation. The tunnel length was about 25 millimeter, and there's about 1 to 2 millimeter of posterior wall left so there was no posterior wall blowout. And then this is the tibial tunnel preparation. So Dr. Cody lifts the stump but tries to keep it attached to the tibial footprint, and then the graft was passed from the tibial to the femoral tunnel. So you see the bone block here. So it was fixed in the femur with a metallic screw, and in the tibia a bioabsorbable screw was used. And the last thing you will see is the graft itself, and we tried to see if there was impingement in extension, and the stump seemed to cause a little impingement, so we used a shaver to remove some part of the stump. You'll see it soon. So we shaved just a stump over the new ACL graft. Yep. Okay, qu'est-ce qui se passe? Oop, oop, oop. So this is her post-op x-rays. She is now 12 days, well, today she's 15 days post-op. On Monday she had 0 to 60 degree of flexion, and she's not on morphine anymore. She doesn't take any medication for pain. And voila.
That's a great presentation. Thanks a lot, Maude. Brenden, you're there. What would you do with this girl?
Yeah, so thanks a lot, Maude. That was great. And for your first time videoing, that was actually an excellent video. So thanks for going through that with us. Yeah, and this is an interesting case. It's a difficult one in terms of all the risk factors that you identified. The one thing I'd say, I guess, is I wouldn't consider hamstring in this patient unless there was a reason not to. I'd go with either the graft selection you had or BTB. And with all of what you've presented, I'd consider augmenting that with a lateral sided procedure now with the results of stability 1. Interesting to see what will happen with stability 2, but I'd be in this population thinking very strongly about augmenting laterally. The other thing that's interesting is you saw her very, very acutely within 10 days. At 15, with a femoral sided tear, I might also consider even looking at the role of repair. Where you saw her so acutely. And I'd have that in my toolkit available if I was able to get her into the OR within that first couple of weeks and make that sort of decision intraoperatively based on what that stump looked like.
Yeah, I think we saw her early. I don't think her MRI was done that early. Yeah.
And the reality is we can almost never get to them fast enough to have that even as an option.
And to be honest with you, like I don't know, like for example, we had one the other day, but now she was an older lady. I think she would have done well possibly with that technique, but I don't know if it's indicated in somebody in their 50s. But I didn't get a sense that she had a lot of good tissue to, the piece had stuck down to the PCL, and I mean, personally, I don't know, Maude, what do you think? Like, do you think that could have gotten reattached back to the femur?
Well, there was not a big stump left,
I
would say.
And I think that's why it's so important to make that decision intraoperatively if you even are going to be considering it. And by and large, I wouldn't have that as my first option, but it'd be something I'd maybe think about in this population if I saw them very acutely like that. And the other thing is I love the idea of remnant preservation. I think that offers the benefit of biology and proprioception. That's been shown now in a couple of studies. So I try to do the same thing, save as much of that stump as I can, and try to go through the center of it with my pin. It also acts as a really nice guide to an anatomic ACL. So you can use that patient's own anatomy to identify it. So I don't like to clear it all the way either.
Nathan?
And then,
Brenden, you
say, and for her, like I would be very slow with rehab in terms of return to sport with her. She's the highest risk patient population. I'd be thinking of definitely at least 9 months. But if she didn't meet functional criteria at 9 months, which she might not, I would go even slower.
Yeah, and that is part of this rehab protocol, is that they really don't want the patients going back much before 9 months, and I strongly endorse that as well. Unfortunately, you see a lot of patients that read the mainstream literature, and everybody thinks they're ready at 6 months, and I don't know what, Nathan, your experience is, or Brenden, I would say hardly anybody's ready at 6 months. So it's a big education piece and refocus piece for the patient, plus or minus family, trainers, coaches, etc.
Yeah, and I think that the rehab part of this is so important. Like, you guys will meet Jose in a few minutes, and one of the things which I'm doing now in my sort of post-op follow-up is all my ACLs I've stolen from Laurie and Mark and Greg out in Banff, and sort of have a bit of an ACL clinic where I get them in and do some basic functional testing and stuff. And especially if you've had a meniscus repair done, like there's no way, like I'm not even really letting you do anything by 6 months, much less return to sport. And it is really stark when you get people to do some physical functional testing, how deficit some people can be even at 9 months. And if you're just going just totally on a theoretical biological marker, I think that it's not great. And but we have physios who are ditching their patients at 6 months. I'm just like, This is like easy money. Like these people should be stuck with you for a while.
Yeah, those are the physios I don't send them back to. 'Cause I actually, so I don't have the functional testing capacity in clinic, but I get a report card from the physiotherapists that I ask them to fill out, and that report card kind of comes back with their 9-month follow-up. And like Nathan, like you said, often I find patients might not even be anywhere near ready at that point, not infrequently.
Are there any comments from anybody? No? Okay. Yeah.
One other question. So, Brenden, when you're talking about your graft selection, do you have a minimum graft size for your patellar tendon, or are you going more to quads these days? One of the things with this age group, I find that, everything's small. Their patellar tendon is small, their hamstrings are small. And if they have any, a lot of these soccer players who are overtraining already at a young age, already running into anterior knee pain, I get sort of a little bit worried about that patellar tendon sometimes.
Yeah. So
sorry, I would say I definitely do more patellar tendon than in this age group than anything else. I find, particularly if you're going towards hamstring, they're very small. You're getting into 6-stranded grafts just to even get close to an 8 millimeter diameter. Sometimes in these younger athletes, female athletes too, the quad tendon can be also quite small. So I tend to go more towards the patellar tendon right now.
Yeah, I think patellar tendon's a great graft. Definitely it was one of the grafts that I was actually originally trained on. So I'm very comfortable with the patellar tendon autograft for sure. But it definitely went out of mainstream for I'd probably say 15 years or so, where everybody went to hamstrings, but now everybody's looking at different types of grafts. So for anybody that's on YouTube, there are more and more papers being published with using quad tendon as well. So that's a definite viable option in this patient population. And the beauty of that graft is it's a little bit more predictable in terms of its size. As part of the Stability 2 study, though, Nathan, to your point, is that if they do have significant anterior knee pain, that would actually be a discriminator. So they'd be excluded if they do have a history of significant anterior knee pain.
Mm-hmm.
And then there's a question. So personally, I do not change my rehab program if I use bone opposed to soft tissue graft. I don't feel like that is a big discriminator for me, but I don't know what you do, Brenden or Nathan. I'll let Brenden talk first.
I use the same rehab program. I think that's a minor point in terms of overall recovery. I think it's all the other factors. What do you do with the meniscus? What do you do with regaining strength over time in their hamstrings and their quads to protect the knee? I think that's all the stuff that really makes the difference.
I think a lot of that came out of the accelerated rehab protocols with trying to do bone patellar bone to speed them up. But my only change is the meniscus dictates the delay. All the other grafts are the same.
Okay. All right, so now we're going to, thanks very much for that question. So now we're going to go to Maude's paper, and this is the preamble study, and she will go over her paper.
Good. So the name of the article is lateral extra-articular tendinitis reduces failure of hamstring tendon autograft ACL reconstruction. It's by Dr. Get-Good et al., and it was published in the American Journal of Sports Medicine in 2020. So the rationale behind the study is that there's a high rate of revision surgery in a very active with pivoting sport population. And usually the existing studies are underpowered, or they have small cohorts, and they needed a better study to evaluate this study question. So does single bundle hamstring ACL reconstruction combined with a modified Lemaire lateral extra-articular tendinitis reduces the rate of ACL reconstruction failure compared to ACL reconstruction alone? And the null hypothesis was that both techniques would have the same outcomes. So it was a randomized control trial that took place in 7 centers in Canada and 2 in Europe. They had the same inclusion criteria as Stability 2, so I won't go over them again. But the exclusion, oh, what happened? Sorry. The exclusion criteria were a previous ACL reconstruction in either knee, a multi-leg injury, or a symptomatic cartilage defect that needed to be addressed at the time of surgery, a significant varus deformity, or a patient that was not skeletally mature or unwilling to be followed up for 2 years. So on the day of surgery, the patient had a knee arthroscopy to confirm the eligibility to the study, as well as to help with randomization. Sorry again. They were then randomized based on surgeon sex and the need for meniscal repair, and they were randomized to ACL reconstruction using autograft hamstrings or autograft hamstring plus LET. And all the grafts that were less than 8 millimeters were either tripled or quadrupled in order to avoid failure due to small grafts. So the post-op protocol was standard, and usually the patient did not have to wear a brace. The surgeon did not have a specific timeline to follow. However, they were encouraged to wait 9 months prior to return to sports. And the patients were not blinded, but the examiner were. So the outcomes, so the primary outcomes was a failure of the ACL reconstruction, either clinical failure that was defined as a mild pivot shift on 2 visits, or a grade 2 or 3 pivot shift at any visit, or a graft rupture that was confirmed during revision surgery or on MRI. And the secondary outcomes were mainly patient-reported outcomes, as well as return to sports, and all the adverse events were reported. So there was no statistical difference between the groups for the characteristic, and they needed 300 patients per group in order to have a power of 80%. So the mean age was 19 years old. Half of the patients were male. About 2/3 were involved in pivoting sports. 90% had a high-grade pivot shift pre-op, and about 40% were hypermobile. So the primary outcome was ACL failure. So in the ACL reconstruction alone group, there was a global failure rate of 40%. However, when only graft failure is considered, it goes down to 11% failure. In the ACL plus LET, there was a 25% failure, but graft failure alone represented a 4% failure rate. So they calculated that they needed to do 7 ACL plus LET in order to prevent 1 ACL graft failure, ACL failure. And as you can see here on the graph, the younger patient had way more events, so either clinical failure or graft failure than the 20 to 25-year-old patient. For the secondary outcomes, so the Marks activity score, this is a score rated out of 4 for each item, which are running, pivoting, cutting, and deceleration. So there was a tendency to have a higher activity level in the ACL reconstruction plus LET compared to ACL alone, which is in blue. However, all the secondary outcomes were not different between the two groups, and the return to sports was 85% in both groups. And for the adverse events, so most were hardware irritation. However, there was one over-constrained lateral compartment, and it was never discussed in the article. It just appeared in the chart there. So the strength of the studies, well, first of all, it's a good, well-powered randomized control trial, the first of its kind. Multiple centers were involved. There was a 2 years follow-up, and the population was quite specific. However, that can also be a limitation. And the main limitations were, first of all, the definition of clinical failure that was subjective, and the measure for clinical failure was also a pivot shift, which is subjective according to a surgeon versus another. The subjects were not blinded, however, the examiners were, and the rehab protocol were not standardized between the centers. So the first thing I wanted to discuss was the extremely high failure rate in, well, both groups. So I found in the literature different populations that were similar to the one studied in this RCT. So first of all, the MOON cohort. So this study compared allograft and autograft ACL reconstruction, and they obtained a 10% failure rate for hamstring reconstruction in a very young population. Oh, encore. The second one was about predictors of failure of ACL reconstruction in also a young cohort, and they had a 15% failure, and the endpoint were also a positive pivot shift and a positive Lachman. This one is from the GPO, so these were pediatric cases, and some of the techniques were fecal sparing. However, that study had a 9% failure rate. And finally, this one is about a high-risk sports athlete. So there was 1,200 patients, and 80% returned to high-risk activities, and about 20% re-injured either their graft or their other ACL, and it was a 15% failure rate for hamstring graft. So why is it that high? Is it because the failure endpoint is not appropriate? Should a grade 1 pivot shift be considered a failure when both groups had the same outcomes? Is it because of the type of the graft that was used? Or is it because this population is a recipe for failure with the age, the return to sport, the hypermobility, and the high-risk sports? But still, the LET seems to reduce graft rupture if we just compare the graft rupture itself, which is 11% versus 4%. So for you, well, the surgeons here, would that have an impact on your current practice, or what is your current practice with these patients? And do you think that the Stability 2 study will have the same outcomes than this one?
Brenden, what did you think of that paper? You've probably seen it. Yeah.
Yeah, thanks a lot, Maude. That was an excellent summary of that paper. I mean, honestly, I think this is one of the landmark papers for ACL surgery in the last decade, really. I think it is one that's been talked about a lot, and it's generated a lot of discussion and additional research and thinking about how we approach patients with ACLs. The things that I learned from this paper, like you identified there, Maude, was that's a high clinical failure rate and a high re-rupture rate. And it made me think about, well, you know, what am I doing in this specific patient population, and how should I approach these patients differently so that I'm not having such a high re-rupture rate as identified in this multi-center trial with a huge number of very excellent surgeons operating on these people. And the other thing that I learned from it was that's a very significant relative risk reduction of, you know, over 60% with addition of the LET. So I think two things that I changed in my practice from this patient or from this study was I've incorporated an LET procedure into my practice in these at-risk patients quite frequently, especially if I'm doing a hamstring graft. And it's also made me think more and more about using different graft alternatives in that high-risk patient population. It's one of several studies that has made me do that and has led to a change in my graft selection since starting practice 5 years ago.
Brenden, do you change your rehab protocol with the LET or no?
I do not. No, I use the same protocol. I essentially use the similar technique as described by Get Good in that stability study, the modified Lemaire. I've drifted away from using a staple and often now just use suture anchors. But other than that, I do pretty much the same way, and I rehab them the exact same way. I don't change anything. Again, so much of my rehab is predicated on what the meniscal pathology is or what associated cartilage pathology I've addressed. And I think that those are the two most important factors when deciding on what type of rehabilitation protocol you're going to do.
Great. Nathan, any comments?
Yeah, it's interesting. Like, I sort of had to bite down really hard on the LET a little bit in that, you know, I do a lot of university sport athletes, and what I was seeing is actually, you know, I think Ontario sort of uptook a little bit faster maybe. And I actually removed a couple staples over the first early days at LET. And this is not a fully benign procedure. I do use it, and in my revisions, almost all my revisions get it. And if I have a hypermobile young person, I'm using it also for them too, or even actually someone older that's hypermobile, I do use it. But it's I don't use a staple. I use an anchor device also. I'm using it more than I used to, and probably the biggest reason I was a little slower on the uptake was I had to take out hardware before I had to do the procedure, so gave me a little bit gun shy at the start of it.
Yeah. And for me, I still very much apply the indications from Get Good's study when I'm deciding on whether or not to do it. I try to apply it to that same patient population. And like Nathan, I do it in almost every revision now. What's your practice, Kathy? When do you kind of go towards that?
It depends. So again, I'm not doing a lot of LETs, but I will do them in a certain subset. So of course, we're part of the Stability 2 study, so we're doing them when indicated in the study. For revisions where I feel like the patient is hypermobile, I'll usually try to use some type of bone, soft tissue type graft, ideally BTB, because most of them have had soft tissue grafts first, so I'll usually use BTB. And then I'll assess them after I'm done the BTB, and if I feel like there's any instability, then I'll add an LET to that as well.
Yeah.
Yeah. Kind of like Nathan or somebody, I'm not sure who mentioned it, but about just, I was a little bit worried too initially about over-constraining that lateral compartment because, I've been around long enough that I used to see some of the old procedures they used to do, over the top, and some of the old IT band ones where you would see that lateral compartment arthritis. So I was a little bit gun shy, I'll tell you initially, but I definitely feel that there's a very important role with this very specific subset of patients for sure.
So Dr. Jose Castillo was born in Mexico City and raised in Querétaro. He attended medical school at Querétaro's Autonomous University and then completed his residency at Mexico's National Autonomous University in Mexico City. He's currently completing a sports medicine, arthroscopy, and joint preservation fellowship here at Dalhousie. Before his fellowship and before residency, he spent a lot of time working with different surgeons. So he has a pretty broad perspective, and really looking forward to hearing him talk about this topic today.
Thank you, Dr. Carr, for the introduction. So I'm talking about almost the same theme, different paper. No disclosure. So this is my paper. It's also from AJSM. It's a physiologic preoperative knee hyperextension as a predictor of failure in ACL revision. It's a cohort. It's from the Mars group. So everything we're going to discuss in this paper, it's regarding ACL revision, not primary ACLs. So the first thing I see when I'm looking at an article, it's the journal, which it's from where it comes. So this one is from AJSM. As we know, it's like the journal of the AUSSM. It has a pretty good impact factor. It's 6.2 in the last year. We can compare it to arthroscopy, which is 4.7, which is not bad at all. We said the journal. Now, when I see the title, I want to see a couple of things. So see if it's brief and concise, which it is. It's interesting because we're talking about a revision surgery of ACL, which is something very usual. The main objective or purpose, which is established in this title, the study type, which is a cohort, and the subjects, who are people with knee hyperextension. A very quick words about the Mars cohort. We know it's a large cohort. There are 83 surgeons, 49 locations in the US and Canada. They're both private and public practices and are over 1,000 patients. So regarding the background and introduction of the article, it's concise and direct. It speaks about previous literature, even though most of the data it's in the introduction, it's about primary ACL reconstruction. The purpose and justification of the study, it's that hyperextension is linked to failure of the graft, not precisely in revision settings, but it's been thought about it. And the hypothesis of the paper is that hyperextension of the knee of 5 or more degrees is an independent factor for graft failure after 2 years, obviously in revision surgery. And this gives me the first point I want to talk about. So in the bottom of the screen, we can see a quick image of how we assess the hyperlaxity, which is the Biden score. And one of those is the knee hyperextension. So from the initial paper of Biden, we see that he uses 10 degrees of hyperextension of the knees. And the actual, the literature we are still using, they also use 10 degrees as a cut. I don't know why this article uses only 5 degrees as a cutoff. Afterwards, we can continue with the methods. We see it's a prospective cohort. For the data collection, it was done with an examiner anesthesia once the patient was on the OR room. And they assessed the range of motion of both knees. There's the next thing I want to discuss. They used 2 parameters. One was a goniometer, which actually gives the degrees of hyperextension, and in other authors use the distance between the heel and the bed. And they said that 1 centimeter was equivalent to 1 degree, which kind of makes no sense. At some sort it is, but it's not very precise, and it's one of the things you're actually measuring in this paper. And another important thing was that the follow-up was only a phone call. So at 2 years, they contacted the patient and they asked them if they had a new surgery where they had a new ACL reconstruction or a new surgery that shows that the graft was tear, or a new MRI after the revision surgery that said that the graft was torn. The inclusion criteria was the same as the Mars cohort, which is almost any revision ACL surgery, which also kinds of make the things not very clear because they included all the patients, different to the one that we saw previously. Here they included patients with cartilage injuries, meniscus injuries, multi-ligament injuries. So some of those injuries can even give you hyperextension, maybe a posterior coronal and a posterior cruciate ligament. Also, they excluded 54 patients because they have a double bundle ACL reconstruction, which they say that that might restrict the knee hyperextension in the post-op setting. Patients with missing data and the follow-up. So they ended up with 1,145 patients. They made 2 groups, so it's the hyperextension group and the non-hyperextension group. Both of the groups, they are very even. So in age, sex, almost all of the patients were in the first revision. The male-female rate was almost the same. Allograft and autograft was almost the same. So very even comparison groups. And when we see the results, we see there's an overall graft of 3%. Only 34% of the patients had a new injury. So as we saw the results that Maude show, even in primary settings, the failure of the grafts, it's even higher. I think this is underestimated because the way they assessed the failure of the surgery, it's not the best. They found 3 independent factors related to the graft failure, which was age with odds ratio of 3.6, that the patient had allograft rather than autograft, which with odds ratio of 3.3. And what they were proving is the hyperextension with an odds ratio of 2.1. So we can see that the patients with hyperextension had a 3.2% failure, and the patients none with hyperextension, they had 2.85, which was not a great difference. And they concluded that hyperextension is an independent significant factor of graft failure in revision ACL reconstruction. As the strengths of this paper, I think that being one of Mars branches, it's one of their strengths. which give them a large population in a multi-center setting. A lot of experienced surgeons and a 2-year follow-up, which could be a strength or a limitation. The limitations you see on the left of the screen are the one that the author actually disclosed in their paper. So there are different surgeons doing the surgeries. So they are fixating the graft at different knee flexion angles, and they also use different fixation methods. And the assessment of failure. And the ones on the right are the ones that we went through this presentation. So why they use 5 and not 10 degrees as a cutoff. Why they think that 1 centimeter of heel bed distance is the same as 1 degree. In the article, they mention at some point patient-reported outcomes, and they're not discussed in the results or in the discussion. That may give a little bit more of information, maybe. Why they include multi-ligament injuries, and why they use the phone call as an assessment. And that's it. Thank you so much.
Thank you very much, Jose. It's a really good review. I think that I agree. One of the big things that when I look at this paper, when you look at the last paper comparison, is the difference in failure rate, and there's a pretty stark difference between the two. Brenden, any thoughts on that, and why the discrepancy of it's pretty big for what we were talking about before?
Yeah. Well, first of all, I wish my failure rate was only under 3%. And I think that Jose hit the nail on the head when he highlighted the way they assessed failure. I mean, this was failure rate in a high-risk population because they've already demonstrated failure once. So they're revision ACLs. Inherently you would think that would have a failure rate that would at least match what the rest of the literature shows. A younger population, hyperextensile population as well. I mean, those are all things that make me think of, this may not go so well. But I think it's the way that they did their follow-up without a clinical examination to assess failure. So you're missing a huge swath of potential unstable knees. How many of these patients actually returned to sport? What was their functional status at 2-year follow-up? Were they engaging in activities that, if they had an incompetent graft, would even manifest itself? And I think that those are likely contributing to that overall low failure rate. And I bet if they'd had a more robust assessment of patients at 2 years, that failure rate would have been quite a bit higher.
I know for myself, actually, it's kind of interesting with the COVID stuff. My follow-up has actually changed. I used to follow people up longer, sort of pre-COVID, and I've actually reduced that just because of the pressures, outside pressures. Too. I know what you guys.
And I do a lot more phone follow-ups.
Yeah. And I'm trying to do sort of email-based proms to also kind of collect those, but there's pros and cons to that. They don't always respond to those. We have so many emails and stuff.
There's a question. So how should we be measuring failure in clinical practice? Our exam, like pivot shift, MRI, patient report, what is an acceptable failure rate? Brenden, you want to tackle that one?
Sure. So I guess I'll just say how I assess failure. I look at, has the patient been able to return to the activities that they want to do? And I think that's a really important one, because I think that plays into so many different factors. If the patient isn't satisfied and able to return back to the activities that they want to do, it's going to affect their physical health, their mental health, particularly in this young patient population who identifies so much with their sport. You take an 18-year-old high school athlete, like their sport is their life often. And so if they can't get back to that because they still feel like their knee's unstable or they have pain in their knee, then I would consider that not a successful intervention. And then the big one for me would be, do they report symptoms of instability in the knee? So if I have a patient come back with a positive Lockman, a grade 2 Lockman, and they have great patient-reported outcome measures, or their knee feels stable to them and they're engaged in their activities, I think from a research standpoint, that's important to know, but from a clinical standpoint, I don't think that matters. I think that patient has had a successful outcome at that point in time, and I would accept that as a success. So that would be how I investigate it, and I wouldn't even go on to getting an MRI unless a patient was reporting one of those factors, saying that their knee felt unstable, that they had significant ongoing pain or recurrent effusions or things like that, and that would prompt me to investigate. So really, for clinical practice, I don't weigh too much on the failure that they're describing in some of these studies in terms of clinical failure as opposed to structural failure of the graft.
So Brenden, what do you look for? Like, let's say you get an MRI in that patient, because you'll see that every once in a while, right? So you'll have done like either a primary ACL or a revision ACL, and the patient reports instability, and you get an MRI, and the graft looks good.
Mm-hmm.
Is there anything you look at on your MRI, or is there anything, like, what would you do in that scenario?
So yeah, I guess I'm looking at what other potential missed pathology there might have been. So I'm looking back at my physical examination, looking back at the MRI scan, looking at their posterolateral corner if I missed something there. I'm looking to see if they have any meniscal deficiencies or meniscal tears that were either missed the first time, particularly something like a meniscal root. Thinking perhaps looking really carefully at that medial meniscal capsular attachment, seeing if they have something like a ramp lesion that was maybe not assessed the first time around. I'm looking at tunnel position and graft position and orientation to see if there's malposition that might be leading to a sense of ongoing instability. I guess those are the things I'm looking for, because in that patient who's unsatisfied with their knee function and is reporting instability, even if their graft's not intact, even if their graft does appear intact on imaging, I'm thinking that there's something happening in that knee that's creating instability, and that I'm going to be trying to address.
I find the tricky part for me is that a lot of times when you're doing a big meniscus repair and an ACL, nothing looks totally normal even at a year, and so when I'm in these situations, I sort of have a talk with the patient. Say, listen, we're going to get an MRI, we're going to review it. There's going to be stuff that looks abnormal. We're going to walk through that MRI and piece by piece sort of tease out what's relevant to your exam and to your history, and then talk about what needs to be done. But I prepare them like there's going to be stuff that's abnormal in this, and we're going to work through it sort of together, kind of thing.
And Jose, I know you mentioned something in the paper. Do you think it makes a big difference if you tension the graft at 0 or 30?
I think it makes a difference at some point, but I don't think in the overall it makes a whole difference, because you're doing an anatomic reconstruction or something that you want to make it isometric. So either if you fix it theoretically, if it's isometric, either at 0 or 90 degrees, it should be the same length. So I don't think that makes such a difference.
Thank you for joining us tonight. We hope you enjoy our first hybrid journal club. Look forward to hosting you at our future sports medicine journal clubs. But before we go, I'd like to take a moment to thank everyone who made this event possible. Thank you, Dr. Sheehan, for being our guest moderator tonight. And thank you very much, Dr. Cody and Urquhart, for contributing to this evening's discussion. Both of our fellows, Maude and Jose, for their great presentations, intriguing discussions. We had a wonderful AV tech, Charles Skinner, our research team to be able to pull this off. Sarah, Lauren, G, Ben, Sarah, for making this night a huge success. So thanks again for tuning in. We hope to see you during our next Hybrid Journal Club, which will be in November. Have a good night.